team as well as Dr. Nisha Madam as well as Dr. Nitin. And we are presenting a case of bone disease from Madurai Medical College. And I will share, Doctor, you can, Dr. Sindhu, you can stop it. I will share it from my end.
Okay. Okay.
Yeah, you can proceed.
Okay, sir. Good evening, teachers. Today I'll be presenting a patient who is a 2.5-year-old female child who presented with widening of wrist and progressive bowing of the lower limbs since 1 year of age. And history of presenting illness, the baby was apparently normal till 1 year of age. Then parents noticed that she had progressive widening of both the wrists and history of progressive bowing of bilateral lower limbs noticed for past 8 months, and history of poor height gain as noticed by parents, and history of delayed dentition, and history of malalignment of teeth. These were the complaints with which the child presented to our OPD. And
yeah, just a minute. So I think Dr. Parag, you may start it. So what are the possibilities from the endocrinologist point of view or regarding these main complaints?
Yes, sir. So we have a 2.5-year female child who is presented with progressive widening of wrists and both the lower limbs going since 1 year of age. So presentation in this age group most likely it seems to be rickets, and rickets most likely it appears to be nutritional rickets, vitamin D deficiency rickets. Apart from that, I would also like to keep the other differential diagnosis of vitamin D resistant rickets also in this case. And because hypophosphatemic rickets general presence after 1 year of age, I would like to keep it very much short down the line. And besides these, I would also like to consider hypophosphatasia in this check.
We could not able to hear you well, but anyway, that's okay, no issues. And Dr. Srihari, what is the dental involvement in metabolic bone disease? What are the metabolic bone disease that have dental involvement? You unmuted, please.
In rickets, there can be a delay in dentition. Delay can occur in both nutritional rickets as well as it can occur in other forms of calcipenic rickets. In specific forms of in hypophosphatemic rickets, we can expect sterile dental abscess, sir, mainly in XLH. In considering this age, sometimes there can be loosening and falling out of teeth that is also seen in metabolic bone disease like hypophosphatasia.
So all type of rickets are what are the types of rickets where you may expect a dental involvement? So one is the hypophosphatemic rickets. Any other apart from the rickets, any other bone disease there is a dental involvement? Yeah, Dr. Malik.
Yeah.
So apart from rickets, any other bone disease or any other involvement of dentitions? So you can see in the fluorosis also, there may be a different thing, but then osteogenesis imperfecta. So you think it's broadly actually, okay, whenever you have this thing. Okay. Yeah, Dr. Sinju, you can proceed.
Okay, sir. There was no history of twitching of upper limb or lower limb or seizures, no history of dental abscess, no history of fractures, no history of hearing abnormalities or chest deformity, and no history of polyuria, no history of abdominal pain or loose stools, no history of alopecia, no history of delayed wound healing or bleeding gums, and no history of excessive tiredness or constipation, and no history of chest pain, palpitations, or generalized edema.
So what are the non-skeletal manifestations or non-skeletal presentations of rickets? What are the things you may expect? Who is Dr. Ramya? You can unmute it and you can.
Sir, features of non-skeletal manifestations like hypotonia, myopathy, then failure to thrive, irritability, seizures, and tetany can be present in rickets.
Yeah, so yeah, good. So myopathy and hypotonia,
Then
irritability,
seizures.
failure to thrive. Okay,
Recurrent respiratory tract infections.
okay.
Yes, sir.
And short stature also.
Yes, sir.
Okay, but that may be. And this alopecia also, some non-skeletal manifestations. And this polyuria also. Okay. So what are the causes of myopathy in rickets?
Vitamin D
deficiency associated with calcipenic rickets is a common factor.
Vitamin D deficiency causes myopathy.
Vitamin D is
What are the mechanisms?
There's a vitamin D
Vitamin D
related calcium. Go ahead.
Only one can, yeah. Yeah, continue. Who is answering? Yeah.
Go ahead, please.
So
So
how?
vitamin D is important for the uptake of calcium into the sarcoplasmic reticulum, and vitamin D deficiency can produce type 1 muscle atrophy, sir.
Type 1 or type 2?
Type 2 muscle fiber atrophy, sir.
Okay, so that is one. Another one?
Then it is important for the production of muscle proteins like actin and troponin. Synthesis requires vitamin D mediated calcium uptake.
Then any other?
In patients with tumor-induced osteomalacia, even hypophosphatemia per se can cause proximal muscle weakness.
Okay, so the hypophosphatemia, not related to tumor, it's a non-tumoral also. So the hypophosphatemia and vitamin D deficiency and muscle and hypocalcemia also. Okay. Yeah, Dr. Sinju, you can proceed.
Okay, so birth history, our patient was a third born of second degree consanguineous marriage, delivered as full term, birth weight is 2.7 kg, and no history of respiratory distress or NICU admissions following birth. And we can see that there is a history of sibling death, early sibling death at 1.5 years and 1 year. In the first two children died of recurrent seizures.
So what are the metabolic bone diseases that runs in family? Yeah, who is but Srihari, you can. Yeah. So what are the metabolic bone diseases? Then we will come to rickets at the last. So overall, what are the metabolic bone diseases that can runs in family? Or family history is important. What are the metabolic bone diseases?
Sir, osteogenesis imperfecta. And then even in VDDR, vitamin D dependent rickets, type 1 as well as type 2. X-linked hypophosphatemic rickets is transmitted through X-linked dominant inheritance, and also hypophosphatemic rickets, we have autosomal dominant as well as recessive types, sir. Hypophosphatasia, again, in this neonatal age group, it can present with the family history being important. And then we have pseudo hypoparathyroidism, and also some genetic causes of hypoparathyroidism, which can present with recurrent seizures and hypocalcemia, sir.
So any other metabolic bone diseases anyone wants to attempt? So that is gain of function mutation. So what are the
sir, Jansen's metaphyseal chondrodysplasia. It can due to the PTH receptor activating mutation can cause skeletal deformity.
Any other? So what is in tumoral calcinosis? What is the
GAL-NT3 mutation?
That is also can happen in
Yes, sir.
Okay. So yeah, that is injurious.
Okay. So antenatally, it was a booked and immunized pregnancy, uneven full, and postnatally the baby was breastfed exclusively up to 6 months of age and continued till 2 years, and supplemental food were started after 6 months. Cow's milk was introduced after 2 years of age, and routine vitamin D supplements were given from birth, and still continuing to give vitamin D supplements.
So what is the common age of presentation in infants, vitamin D deficiency or any rickets? What is the ideal time or what is the common period?
3 to 18 months.
Once the baby starts to crawl, it can even present at infancy and also it can present once the baby starts to crawl. So.
Why not
Usually after
immediately?
10 months.
Why not immediately? If genetic form of rickets, why it is not manifesting immediately after birth?
Maternal source can.
Usually, mother's vitamin D, if it is a vitamin D supplement, sufficiency is present in mother, that is enough to carry over for at least about 8 to 12 weeks after delivery. The manifestations also will require that the PTH be prolonged for a slightly prolonged period of time, after which the skeletal manifestations usually occur. So unless it is a very grossly vitamin D deficient mother, the symptoms usually do not occur, not be manifested as craniotabes and all immediately after delivery.
Okay. Yeah, Dr. Sanjay, you can proceed.
Okay. So dietary history, complementary feeds were started with ragi, with sugar, then idli, rice and sambar. So total calcium intake from food and supplements came to around 500 milligram per day, and total calorie intake was 960 kilocalories. Deficit of 240 kilocalories was there, which didn't meet the requirement of 1,300 kilocalories in this age group. So family history, as already mentioned, history of death of 2 elder siblings at the age of 1 and 1.5 years due to recurrent seizure episodes. And the reason was not diagnosed, but they remember it as recurrent seizure episodes.
So what could be the possibilities in this case?
Considering the deformities present in this child, it can be due to hypocalcemic seizures, probably.
But hypocalcemic seizures, death is, unless it is very prolonged seizures, it is common. Otherwise, it is not very quite common to have, or maybe some sequelae of the seizures. That may be some aspiration, some aspirate, that pneumonitis, something it may be there. Or maybe any other possibilities?
Maybe
So the
recurrent
infection which happens because of the rickets per se or hypocalcemia per se, like aspiration, respiratory infections.
Or okay, respiratory muscle dysfunction or some, okay. And what are the sources of calcium and vitamin D? What are the nutritional sources and how much it contains? The normal common sources.
calcium, breast milk is a ragi, milk and milk products. They contain means calcium, and also
how much it
legume.
contains breast milk?
Breast milk, sir,
30
it's a
Yeah.
Breast milk is 20 international
20.
units, sir, followed by cow's milk,
Vitamin.
which will give around 120, and followed by goat milk, which will be around 150. The maximum is present in the buffalo milk, which is around 200 international units. Apart from that, coming to the pulses and the cereals,
And
ragi.
how much calcium content of these breast cows and other milk, buffalo milk, calcium content?
The calcium content in cow's milk, it is around 120, sir. 120 mg.
Milligram per 100
Milligrams,
ml.
sir, per 100 ml.
Okay. Yeah. Breast milk?
Breast milk, I'm not sure about the calcium content, sir.
30 mg per 100 ml, sir.
ml.
Okay. Yeah. So what are the other high rich sources of vitamin D?
Yes, sir. Sesame seeds, they contain a high source. We can use it. Even the drumstick leaves, the spinach drumstick leaf has a very good source of calcium. Both these have a good source of calcium.
So for vitamin D?
Vitamin D.
Mushrooms are the
Mushroom.
major source.
The animal source like
the fishes and cod liver.
Cod liver oil, sir.
Mushrooms,
Animal
cod
source.
liver oil,
Mackerel.
salmon.
Cod liver oil and fishes.
Yeah, salmon fish is how much vitamin D? Around 100 or 100 gram of salmon fish contains how much vitamin D? So predominantly vitamin D is highly is in animal source rather than the plant source. And animal source maybe this cod liver oil or salmon fish, everything is around 500 to 1000 international units. That is the approximate. Okay, so the diet and nutrition history is important for to rule out simple vitamin D deficiency. So that is the main things we should understand. Okay, yeah, Dr. Sinju, please.
As a developmental history, she had a history of delayed motor milestones. Started to sit with support only by 10 months and without support by 12 months. Crawling started at 12 months, standing with support by 18 months, and standing without support only by 2 years. And baby started to walk without support only by 2 years and 3 months of age. And history of delayed dentition is present, and first tooth appeared only at 13 months, which was upper incisors, and no history of mental retardation or speech delay, or no history of other delay in the fine skills. So then treatment history. Baby was treated with calcium supplements from birth by pediatrician for delayed motor development. Later, they consulted a local hospital because she had delay in the motor development, and she was started on calcium along with vitamin D syrup, which they remember it as 5 ml twice daily. So to summarize, so 2.5-year-old child born of second degree consanguinity, positive family history of recurrent seizures leading to early neonatal deaths of 2 elder siblings, progressive bowing of lower limbs and widening of wrists noticed from 1 year of age with interim calcium and vitamin D supplements. And in addition, short stature, delayed dentition, and delayed motor milestones. So most probably we'll be dealing with a case of metabolic bone disease.
So what is metabolic bone disease?
So metabolic bone disease is any disease which affects either the bone mineralization, osteoid formation, that is metabolic bone disease. Any disorder which affects the osteoid formation or matrix formation or mineralization.
Okay. So yeah, Dr. Ramya, you can. So what are how to classify the rickets? What are the different methods or different ways to classify rickets?
One set of classification could be calcipenic rickets and phosphopenic rickets. Where in calcipenic rickets, there is involvement of both upper limb and lower limb together, along with weakness, bone pain, fractures. And
just tell that what are types alone, yeah. So
calcipenic,
and
phosphopenic
rickets.
Then vitamin D dependent, and vitamin D resistant rickets.
Okay.
FGF23 dependent and FGF23 independent among the hypophosphatemic rickets.
Okay.
Then.
So these are the main thing. Another one is maybe PTH dependent or PTH, but almost everything. So these are the three the main categories of this thing. And Dr. Parag, you can tell what is the other terminology for using the vitamin D. What is known as a vitamin D resistant rickets? When you suspect, or what is known as a vitamin D resistant rickets?
Yes. So vitamin D resistant rickets include vitamin D dependent rickets type 1.
Actually, your connectivity, sir, we are unable to. It's a voice or this thing. You can anyway, any other person. Yeah, Dr. Malini, you can attempt. When will we call them as a vitamin D resistant rickets?
Hello, sir. After a supplementation for a period of at least 3 to 3 months, if there are no signs of recovery in the forms of biochemistry or skeletal healing, we'll have to term the patient as vitamin D resistant rickets.
What are the types, or what are the other names of vitamin D resistant rickets?
So there are, it is actually otherwise called as dependent rickets. So there are basically 5 types. The VDDR type A, VDDR type 1, 2, and 3. 1 is further subclassified into 1A and 1B. 2 is subclassified into 2A and 2B. And we have VDDR type 3. So 1A is basically a defect of 1-alpha
Yeah,
hydroxy.
we will come across on this thing. Okay. So what is Dr. Sinju's your opinion regarding this history diagnosis, summary of the history?
So this is a child born of second-degree consanguineous marriage, and there is a positive family history of early neonatal deaths also. And then we can see that the baby is on adequate calcium and vitamin D supplements and diet, but still the baby has developed deformities in the form of widening of wrist, and also delayed dentition is present. So maybe we are dealing with a genetic cause of rickets, most probably.
So calciopenic or phosphopenic? What is your?
Since the age of onset is around 1 year, that is less than 2 years, most probably it will be a calcipenic rickets.
And this child doesn't have any seizures.
No, sir, because she was already on calcium and vitamin D supplements. So somehow she was able to maintain the calcium level. So maybe that is the reason she was not having seizures, sir.
Okay. Yeah, you proceed with the history. General examination.
So general examination, nourishment is fair, and there was no pallor, icterus or pedal edema, and no alopecia or epidermal nevus or neurocutaneous markers. Shostak's sign was positive and Trousseau's sign was negative.
So what is the significance of epidermal nevi? Dr. Srihari.
Epidermal nevi can occur in linear nevi syndrome, which is a form of hypophosphatemic rickets, sir.
Okay. Yeah. So okay. Yeah, proceed.
Okay. So anthropometry, height is 73 centimeter, which was less than 4.75 SDS. BMI is 13.20, and genu valgum was present, and intermalleolar distance is 8 centimeter.
So what is intermalleolar distance and what is intercondylar distance? Where you will be using intermalleolar and where you will be using intercondylar?
In case of genu varum deformity, we use the intercondylar distance, and in case of genu valgum deformity, we use the intermalleolar distance, which is measured by making the child lie on the bed. And for measuring the intercondylar distance, we have to approximate the both malleoli, and you have to measure between the two condyles. If it is more than 5 centimeter, that indicates that it is significant. And for measuring the intermalleolar distance, we have to approximate the two condyles and measure the two between the two malleoli. And if it is more than 8 centimeter, it is significant.
Okay. And upper segment, lower segment ratio, when it is significant in while discussing the case of metabolic bone disease.
There is some amount of disproportionate short stature associated with metabolic bone disease, usually associated with a preserved trunk length, but a limb length will be lesser. So
For
that
example,
in hypophosphatemic rickets and XLH, you'll see that the trunk length is preserved and there is a relative shortening of the limbs. And one of these features are predominantly risk factors for patient having a poorer prognosis. So this the proportions should be measured properly.
And you tell some example of disproportionate short statures due to the metabolic bone disease.
Skeletal dysplasia.
For example, what are the skeletal dysplasia? You may get a disproportionate short stature. What is most common?
Achondroplasia.
Achondroplasia.
Achondroplasia. Then
Metaphyseal dysplasia.
so spondyloepiphyseal dysplasia or hypochondroplasia. So there are a lot of subtypes or classifications. Okay. Yeah. We'll move to the other. Yeah, so Dr. Sinju, proceed.
So these are the general examination findings. So we can see that there is malalignment of the teeth, and missing teeth is also there. And we can see the rachitic rosary and widening of the wrist.
So what is indicate this rachitic rosary?
This is due to the hypertrophy of the chondrocyte that is at the level of the costochondral junction. So that is one of the sign of rickets, sir.
Okay. And why the wrist widening is happening?
So wrist widening is again due to the hypertrophy of the chondrocytes, and because of which, because of the lack of apoptosis of the chondrocytes, sir. So there will be metaphyseal widening, widening of the growth plate. So that results in widening of the wrist. When the pressure is applied, pressure, that is when the child starts to crawl, because of that pressure, that end of the bones becomes widened because of the longitudinal pressure.
Okay.
So these are the lower limb findings. Knock knees are present, and anterior convexity of the tibia, that is saber shin is present. Then we can also see the widening of the ankle joint, and also double malleoli.
So what is double malleoli?
So double malleoli is again due to the hypertrophy of the chondrocytes. So it will appear as pseudo, like it will appear that the patient is having two malleoli, but again this is due to the irregular pressure over the joints at the end of the tibia.
Okay. Yeah. Any other positive findings are there? What is this in the umbilicus actually?
So that is a hypopigmented patch, sir, that was present since birth.
Okay. And significant or insignificant?
So hypopigmented single patch, not significant, sir.
Okay. Yeah, you proceed.
So then we proceeded with the investigations. Since we were suspecting metabolic bone disease, so we did a calcium, phosphorus, 25-hydroxy vitamin D, PTH and ALP on first visit. But since the patient was irregularly treated with calcium and vitamin D supplements, we could not arrive at any positive findings except for the elevated ALP levels. So which signified increased bone turnover. So now, so what we did was we stopped calcium vitamin D supplements for 2 weeks, and then we repeated all the tests. So corrected albumin corrected calcium was 4.2, phosphorus was 3.2, 25-hydroxy vitamin D was 52, which was normal, but 125-dihydroxy vitamin D was only 24.2, which was in the lower range, and ALP was elevated. So the impression is hypocalcemia with
We can ask the other this thing. So
okay.
who is going to? So how to interpret this report and what is the finding and yeah, any?
So in this patient, the calcium is low with a normal phosphorus with a raised alkaline phosphatase. Because there is hypocalcemia as a response to it, there is secondary hyperparathyroidism, because of which PTH is elevated, sir. And coming to the causative of it, they have done 25-hydroxy and 125. 25 is normal, but 125 is low, means there is a problem with conversion of 25 to 125. Probably 1-alpha hydroxylase is the problem which is not getting converted. So probably it is a type of vitamin D deficiency rickets type 1A.
And so what are the rickets you may expect normal vitamin D level?
Normal vitamin
VDDR type 1.
VDR1 A 25.
Inappropriately normal type 2 also.
So type 2
vitamin
also.
D, vitamin type 2.
Type 2A and B.
Type 2.
No, type C. Type 3.
So VDDR type 1A, then
VDDR type 2A and B, and VDDR type 3.
okay. And so what is the most important if you are given one choice of test, only the single most important biochemical test to find out the cause of rickets, what will be asking? Yeah. So previously it was thought that anyway you need multiple tests, but single most important test or single most important denominator is a phosphate level. So based on the phosphate level, almost all the classification of vitamin D or resistance or vitamin D deficiency rickets are being evaluated. Why there is a vitamin D is more important? Why not active vitamin D we are measuring? What is the difference, or what is the why the assays are doing vitamin D, not the active vitamin D? What is the drawback of vitamin D versus 125 dihydroxy vitamin D measurement?
Sir, 125 dihydroxy vitamin D has.
is so stable.
Yeah.
25 vitamin D is more stable as compared to 125
Dr.
vitamin D.
Palak Agarwal, we could not be able to hear. So the connectivity is breaking your voice. So we are unable to hear it. Otherwise, you can come and join any other this thing or anyway. Otherwise, yeah.
Sir, the half-life of 125 hydroxy vitamin D is short. It is only 4 to 6 hours, and there is wide fluctuation in the serum levels. So it is very difficult to interpret because of the fluctuation. Our 25 hydroxy vitamin D, it is stable, and also there is not much of fluctuation in the levels.
Any other
So it is
point?
more abundant than 125 dihydroxy vitamin D, though it is biologically less active than 125. The blood value is much more than 125, so it makes the assays easier and less expensive and less cumbersome. So so that is why 25 hydroxy vitamin
Again,
D
is the half-life. So half-life is more with the 25 hydroxy vitamin D. How much half-life?
3 weeks.
So 3 weeks.
3 to 4
Whereas
weeks.
125 dihydroxy is a hours.
Sir,
Actually.
4 hours.
6 hours.
So there is a lot of fluctuations in the level. There is maybe a minute-to-minute regulation. So we may not the standard level. We may not like peak and trough like that. So that will vary. 125 and technically demanding also. So 125. What was the method was commonly used in previously assay methodology. So what was the previous assay? Any ideas there? So previously RIA was used, radioimmunoassay. Now we have ELISA again. Chemi also some of the labs now start doing. So the previously RIA, it's a technically challenging methods, but now CLIA also has been come up, and LCMS also again steroid this thing. So and so okay. And so based on the things, what is the interpretation? Yeah, based on the above report. Yeah, Dr. Sinju, you can.
Sir, so based on the reports, we can see that there is hypocalcemia and there is normal 25 hydroxy vitamin D and low 125 dihydroxy vitamin D and elevated ALP. So this means that it is due to vitamin D dependent type 1A because of the low 125 dihydroxy vitamin D levels. And
whenever you are interpreting some 2-3 value and you take the mean value, and so it has to be done in whenever you are suspicious or this thing. But okay. So yeah, proceed.
So then in order to rule out other causes of rickets, we did an ABG to rule out renal rickets. So it was normal, and urine routine was done, which was negative for glucose, protein, and pH was 6. So then we did 24-hour urine analysis. So we can see that there is a low calcium and low phosphorus excretion through the urine. So that again confirms the diagnosis of hypocalcemic rickets. Calcipenic rickets.
So when you will suspect RTA, rickets due to RTA, what are the clinical parameters?
Renal RTA, the onset of rickets will be in the childhood period rather than in the infancy period, and the patient will have features like polyuria and failure to thrive also. Then the patient will have features of acidosis, like in ABG we can see metabolic acidosis. Then
History of renal stones.
Hypokalemia also, sir. Whenever there is
Hypokalemia.
hypokalemia, renal stone.
History of stones, renal stones.
Then
History of hearing loss, eye defects which have been evaluated.
Eye defects means what eye this thing?
Sir, certain conditions like Wilson's disease will
Okay.
present with cataract,
Cystinosis.
Yeah, cystinosis.
Lowe syndrome.
Wilson disease. Okay. So predominant main important thing is hypokalemia. So whenever there is a severe hypokalemia along with hypocalcemia, you always suspect RTA, renal tubular acidosis. And what is the counterpart in adult? Where you will get this type of this thing? RTA you may expect in which adult patients?
Multiple myeloma. Multiple myeloma.
Commonly, autoimmune diseases like Sjogren's syndrome.
Sjogren's syndrome. So Sjogren is one of the most important. Maybe medicine side, some cases admitted and very hypocalcemia and hypokalemia. Always should suspect Sjogren's. Okay, yeah. And 24-hour urine analysis, how to interpret, and what is the importance of doing this test in rickets? Any case of rickets, what is the importance of doing urine analysis, 24-hour urine analysis? So 1, 2, 3, 4, like that you can enumerate. Yeah.
And in patients with
hypercalciuria.
So what would happen? Hypercalciuria. When will you diagnose or when will you say it is hypercalciuria? What is the level?
Urinary calcium levels more than 4 mg per kg.
Okay, so 4 mg per kg per day. Okay, the 24 hours. Then to rule out hypercalciuric, okay, then
HHRH. In certain forms of rickets with hypercalciuria, like in HHRH.
Then
Tense disease.
Okay.
Then again,
hypophosphatemic rickets to look at whether there is phosphaturia present or not by calculating
the most important. TMP-GFR calculation.
As part of follow-up, sir, if the patient is already on treatment, as part of follow-up, if the patient is already on calcitriol, we should know whether there is urinary hypercalciuria.
Yeah, definitely, exactly. So to assess the toxic level or to find out the dose titrations and avoid the nephrocalcinosis, again, you have to periodically evaluate this thing. And any other?
So to rule out in patients with proximal renal tubular acidosis, 24 is not required, but even we have to look at the urine amino acid, urine glucose, and urine proteins.
Okay. Yeah. Yeah, Sinju, proceed.
Then these are the X-ray images. So we can see that there is in the upper limb X-ray, there is a fraying, cupping of the distal margins of the radius, ulna, metacarpals, and phalanges. And
so, yeah. So why it is happening? Splaying. What is meaning of splaying, fraying, and cupping?
there is a irregular.
Demineralization. Basically, because of the demineralization of the bone, there is softening of the bones, and as the child starts to crawl, there is the mechanical stress occurs along the long axis of the metaphysis. So the new bone is laid down at the metaphysis, and that area becomes irregular and distinct. That is called as the fraying of the metaphysis. And because of the pressure, because of the softened bones, there can be cupping of the metaphysis, and spreading a part of the metaphyseal end is called as the splaying of the metaphysis.
Okay.
So this is a lower limb X-ray. So we can see that there is again fraying and cupping of the metaphysis of the lower end of femur and lower end of tibia and upper end of tibia, and also metatarsals and phalanges.
So what is the loser zone? Where you will get, and what are the differential diagnoses? Yeah, other people. Yeah.
Loser zone are otherwise called as pseudofractures, sir. This actually occurs because of the mechanical stress of these pulsating arteries on the unmineralized or hypomineralized growth plates. These occur and then in specific sites like the femoral neck, then the femoral condyles, medial femoral condyle, the proximal ulna, the scapula. These are basically these are incomplete. We see this in the X-ray as lucent incomplete lesions, which do not actually cross the entirety of the cortex.
So
And
perpendicular to the
these are
lung.
usually, yes,
It will be
and these are
perpendicular.
usually symmetrical and bilateral in contrast to true fractures, which are usually unilateral, and there will not be any element of symmetry also.
Yeah.
So our final diagnosis is calcipenic rickets due to vitamin D dependent rickets type 1A.
And what are the differentiating point between calcipenic rickets and phosphopenic rickets?
So calcipenic rickets, age of onset, sir, infancy period, the age of onset will be there. Phosphopenic rickets, the age of onset will be in the childhood, and the deformity will be more severe in the phosphopenic rickets, and the hypocalcemic signs like seizures, tetany, and all these things will be a feature of calcipenic rickets, and then dental abscess is a feature of phosphopenic rickets, and enamel hypoplasia is a feature of calcipenic rickets. Then this is some of the differentiating
Bone
points.
pain,
Any other?
Bone
bone
pain,
pain, bone pain is more
Myotonia.
calcipenic rickets.
Then any other?
In biochemically, we can differentiate based on the peat.
First clinically.
clinical.
So proximal myopathy will be more common in
Phosphopenic rickets.
phosphopenic, and enthesopathies
Enthesopathy is common for
Phosphopenic.
phosphopenic rickets.
and intraosseous membrane also they can happen. And okay, any extraskeletal manifestations?
Dental,
Like
then
alopecia, calcipenic rickets.
Okay. So
Then
biochemically, how to differentiate?
Sir, biochemically, hypocalcemia is not very severe in phosphopenic rickets, and the PTH secondary hyperparathyroidism occurs more commonly with the calcipenic rickets, and the PTH levels are significantly elevated. In phosphopenic rickets, PTH can be just slightly elevated, or usually it is in the normal range. And then ALP levels are also significantly elevated in calcipenic rickets and compared to phosphopenic rickets.
Okay. So how to treat, Dr. Sanjay?
Sir, so calcipenic rickets, so here it is vitamin D dependent rickets type 1A. So here we have to supplement with active form of vitamin D, that is calcitriol, and the dosage will be 0.04 microgram per kg, sir. And in addition to calcitriol, we have to also supplement with vitamin D and calcium supplements also.
Okay. So what are the, so what this slide shows?
So this is just to enumerate the differences between VDDR type 1A and 1B, sir. So here we can see that in both the types we have low, normal to low phosphorus, low calcium. But the only difference in this thing is the levels of 25 hydroxy vitamin D, which will be normal in VDDR type 1A and will be decreased in VDDR type 1B. And 125 dihydroxy vitamin D will be low in 1A and variable in 1B. And also the treatment wise also, both we can try treating with calcitriol 1 to 2 microgram per day. But in addition for VDDR type 1B, we can try calcifediol, which is not widely available. So in this case, we have to treat with calcitriol itself. Then also in another option in VDDR type 1A is alpha calcidiol, 0.5 to 3 microgram per day.
Yeah, question to other panelists. So what are the indications of calcitriol in endocrinology? What are the indications? Yeah.
In,
What are the conditions?
Hypoparathyroidism,
Okay.
and chronic kidney disease, CKD, end stages, and CKD stage 4, starting from stage 4.
Renal tubular acidosis.
Okay.
Hypophosphatemic rickets, sir.
Which renal tubular acidosis you will be using calcitriol?
Proximal renal tubular acidosis, sir.
You have to be specific. So what will happen in distal RTA?
Already the patient will be prone for nephrocalcinosis. So if you use calcitriol, that is.
So any other indications, calcitriol usage? So all hypophosphatemic rickets except
HHRH.
HHRH.
So these are the various reasons calcitriol will be using. Yeah, proceed, Dr. Singh.
So here we have treated the patient with calcitriol 0.25 microgram BD and syrup calcium with vitamin D containing 50 milligram per kg per day of calcium. And we suggested to follow up after 3 months.
So what is the elemental calcium percentage in various different calcium formulation? Yeah, others can answer. So what is the common calcium we are using in day-to-day practice?
Carbon.
So calcium carbonate contain how much elemental calcium?
40%.
40%.
So what is available? So how much? What is the commonly available calcium carbonate?
Telcal 1250 mg contains 500 milligram of elemental calcium, sir.
And vitamin D? Skeletal
250 international units.
250 international units.
Okay. And calcium citrate, how much elemental calcium?
It is 20%.
21%. And what is other calcium available preparations?
Calcium phosphate.
Calcium acetate
acetate.
is there. Acetate.
How much elemental calcium?
So 13%.
Okay. Any other?
13%.
Calcium gluconate?
10%.
9%.
Yeah, 9%. And calcium lactate also some places available. It is
13%.
Around 11 to. So it is a weak actually. So only the. And what is the difference between calcium carbonate and the calcium citrate in administration wise? How to instruct?
Sir, calcium citrate double the dose of. We have to give twice the amount of calcium carbonate that we are already giving to the patient, sir.
And timing?
Depends whether we are giving it with the food or without the food, sir. Calcium citrate, you can give it in acidic. So with the food, it can be given. That is the difference.
And what is the role of vitamin D? What is how to help? It will help. Whether
So
needed.
Vitamin D mainly gives it's a storage form, sir. If we are taking the 20 in this patient, though 125 dihydroxy vitamin D, that's active vitamin D, what is required. We also have to supplement with 25 hydroxy vitamin D. One, it is because the requirement of 125 will come down by giving the 25 hydroxy vitamin D, sir. And also it helps the 25 hydroxy can get converted into 125 hydroxy vitamin D at a higher level. So that's why it has to be given.
And one more is it improves the calcium absorption also. So
Yes,
that
sir.
is one of the main reasons. It should be always we should replenish the vitamin D levels, and so it will be more useful. So how to follow up this case?
So to follow the case, first of all, after 1 month, we can measure the serum calcium phosphorus and serum calcium phosphorus. But after 3 months, we have to do a serum calcium phosphorus 25 hydroxy vitamin D PTH levels, and also we can take radial X-ray to check if the line of
earliest one to whether biochemical or radiology, and what is the time interval you may expect the biochemical and radiological improvement?
The biochemical is the earliest, sir, and serum phosphate is the first parameter to improve.
How yearly?
1 month, sir. 1 month.
Any other different opinion?
1 to 2 weeks, the phosphorus
level
improve by 2 weeks.
Yeah, 2 weeks expect. And radiology?
It will take at least 3 months, sir.
So maybe 2 to 3 months. Okay. So what is this?
So this is the follow-up after 3 months, and we have compared it with the baseline. So when compared to baseline, after treatment, we can see that phosphorus, calcium has improved. 25-hydroxy vitamin D was more or less the same, and we can see that PTH is also coming down.
Okay, yeah, proceed.
So these are the follow-up images. So in this image, we can see the fracture healing line, and cupping fraying has also slightly improved.
So what is the what is the white line of Frankel? What is it?
So it is a line of healing, sir, at the end of between the metaphysis and the physis.
Line of ossification.
Line of ossification.
Yeah. Okay. So any other findings in this X-ray?
Osteopenia is there, so diffuse osteopenia is also.
So this is how many months after treatment?
3 months, sir.
Okay. Yeah, proceed.
Okay, this is the comparison before treatment and after treatment. So when compared to before treatment, we can see that the fraying has slightly improved, and we can see the fracture healing line.
Okay.
So
So
finally,
what is the role of genetics in rickets? What are the rickets? It will be more important, and what is the why we should do genetics? Yeah,
so
any.
Mainly for the family screening, sir, because both vitamin D dependent rickets type 1, type 2, and even VDRR2, 3 also, they're all autosomal recessive. So it helps us in the family counseling. Coming to the hypophosphatemic rickets, like X-linked hypophosphatemic rickets, or might be autosomal dominant, autosomal recessive hypophosphatemic rickets, it's the same thing. So we will be able to counsel the family regarding this condition. So it can be preventable at that time.
And any other indications for genetics? So if in equivocal cases, if unable to identify like a tumor-induced osteomalacia, or whether you are really dealing this genetic form of rickets, then it will be also useful. Unidentified tumor-induced osteomalacia, and anyway, FGF23 will helpful. But so what is the role of FGF23? In what are the cases, what are the situations you will be measuring FGF23?
So in case of hypophosphatemic rickets, to rule out to rule out the genetic causes, in the FX gene mutation, then autosomal dominant hypophosphatemic rickets and recessive forms. So to know whether the FGF23 is elevated, and also in HHRH also we can measure the FGF23 levels, because it will be suppressed in HHRH.
Any other?
Tumor-induced osteomalacia
Tumor-induced
for the
osteomalacia.
quantitative.
It is commonly seen in adults. It is reported in children as well. So for clarification.
So, okay. Madam, it's okay, or shall we? You can ask, madam. I think. Yeah, you can.
So that's fine. Since we started late, we are actually little late. So thank you, Dr. Sridhar and Dr. Sinju, for that excellent case and excellent discussion. And thank you, panelists, for the wonderful interaction. Handing over to Dr. Nitin to conduct the case.
Right, and thank you, Dr. Sridhar, again for agreeing and doing such a great job. So I will now take you through the quiz, and for all the viewers on the Zoom platform and otherwise who are watching through YouTube and on through the PSI website, I think all of you are well aware of how we run the quiz, but still I would definitely take you through the rules of the quiz. I must emphasize again that the quiz has a 10,000 rupees cash prize that you would win. Only one winner would be there. You have to answer correct and you have to answer fast. And that's how you can win. So what you need for the quiz is the Zoom platform where you're watching. In addition to that, you need another smart device, which could be your mobile phone, a tablet, or another computer. And obviously, you need good internet. Just the rules are that they are time-bound questions. So if you don't answer in 15 seconds, you will not be able to score for that particular question. You have to answer early and correct. And the earliest and the correct answer gets the maximum points. The maximum per question would be 1,000. They're all MCQs, only one answer is correct. There's no negative marking. And you could join the quiz by looking at this barcode through your lens, or you could go to the website of menti.com and punch in this particular code. So either ways, you could join. And after you join, you will be able to enter your name. When I move to the next slide, I request you to please enter your correct name so that we can get you the prize appropriately. If your name is not correctly mentioned, then you may, even if you come first, you may not be able to get the prize. So please mention your name correctly. And after the quiz, you should be able to contact me. So at this point in your screen, you should see a green arrow and a thumbs up sign. And I already see more than 22 people who are already joined. We'll wait for another 5 seconds and then go on to the next slide. In total, only 10 questions, and let's see how you do. So I see the numbers are increasing rapidly, and you should be able to enter your name now. So there are 59 players, now 65. So we'll get started now. All of the following are intracellular functions of phosphate except glad most of you have got it right. This is directly from Williams again, and as you see that neuronal activation is a very important function of intracellular calcium and not phosphorus. All the others are important for phosphate ions. Let's see the results. So well done, Dr. Parag. You're leading, but there's close and tough competition. Let's look at the second question now. All of the following are indications for parathyroidectomy in PHPD. A very simple question. I'm sure all of you know this. Very good. So yes, all of you have answered that correctly. Sure, the guidelines are very clear, and if the creatinine clearance is less than 60 ml per minute, that is an indication, not more than 60 ml per minute. So I'm glad most of you have got that right. Well done, Dr. Parag, still leading, but very narrowly. All of the following are causes of PTH, independent causes of hypercalcemia, except one of the causes is PTH dependent. Excellent. So all of you seem to be reading your Williams quite well. So that's good. Let's look at the scores. So as you see, each question makes a difference. Let's move on to the fourth question. Talking vitamin D synthesis. See the options better on your screen. Right, so that was a difficult one, but yes, that's the correct answer. That will change a lot of scores. The Tazar Rizvi is now leading with 3,600 points. You still have another 6 questions to go. People get it right, so every quiz should have a mix of tough and easy questions, but again changing scores quite a lot. Dr. RK, your name is not correct, but let's see how you go. Last 5 questions. True or false? Just 2 options. Right, so not all people got it right. The percentage was 30 versus 6%. So yes, it can increase dental abscesses. Let's see what happens to the scores. Again, a big change. Dr. Lakshmi S is now leading with 4,450 points, but we have 4 more questions to go. Simple basic science question. Yes, respiratory acidosis is the correct answer. Again, quite simply from Williams. Dr. Ravisha is now leading, so every question had a different winner. Let's see what happens to the last question. We've got 3 more questions to go. Again, these are better visible on your phone. Very simple question, I would say. Yes, majority have got it right. So again, impaired renal phosphate excretion. Acromegaly, phosphate is a sign of activity, disease activity. So that's because of the impaired renal phosphate excretion. Let's look at the results here. Dr. Palini Vail from Madurai now leading the scoreboard. We've got 2 more questions. Good luck to all of you. Hypophosphatasia, a rare disease. What's false? Very simple again. Just read a few lines about it given in different textbooks or articles. Yes, it's an autosomal recessive disease. Marrow transplant has been shown to be useful. Tough competition. Ravisha is now leading. We move on to the last question of the day. Good luck to all of you. Simple. Sure, you've seen all of that clinically. Which bone have you not seen at it? Right. Wonderful. It's seen in long bone, so that was the right answer. Let's see who's the winner of the quiz today. So congratulations, Dr. Ravisha, for winning the quiz today. I just request you to send me a WhatsApp message so that we can contact you and get you the prize money. But we come to an end of this particular quiz session today and the session today. And over to Dr. Nisha Madam for the last word.
Excellent. Congratulations, Dr. Ravisha. And thank you, Dr. Nitin, for that wonderful quiz. And once again, thank you, Dr. Sridhar, for the excellent session on rickets. So till we meet again next September Wednesday, September 25th, with yet another session. It's bye from Endocrine Society of India. Thank you.
Thank you. Bye-bye. Good night.